So what I wanted to talk to you guys about a little bit is talk about a new FDA-approved drug for ovarian cancer that some of you may have heard about. I don't know why this is going in different directions. Also kind of talk about the treatment overall, discuss clinical trials, and some different targeting approaches. So let's talk about ovarian cancer treatment overall. I think most of you, unfortunately, know more about ovarian cancer treatment than you want to or wish to. But I think when we think about ovarian cancer treatment, we kind of think of it in different phases. So the first is kind of that initial therapy. And I think the initial therapy, like all of ovarian cancer treatment, is very individualized. Everybody's experience is going to be different depending on the situation, other medical conditions, age, where the cancer is growing. And so your experience might be very different than the person sitting next to you. But in general, it's a combination of surgery and chemotherapy. So we need to work very closely with our surgical colleagues. And it's really a multidisciplinary approach. So when we think about the chemotherapy part, it's usually a combination of a carboplatin or a platinum drug, usually carboplatin, and then a taxane, usually paclitaxel. Some of you may have had allergic reactions, unfortunately, and Sherry rushes in and saves the day. But then there are other approaches that we can use, but it's usually a combination of carboplatin and paclitaxel, and then either surgery kind of at diagnosis, or maybe after a couple cycles of treatment when we can get the tumor to shrink and make that surgery a little bit easier. And then, what's been new over the past, 5 to 7 years is kind of this maintenance therapy approach. And so we'll talk a little bit about maintenance therapy. So maintenance therapy is, adding an additional treatment after kind of those initial 6 rounds of chemotherapy. So there's some good points to that, but there are also some downsides to that, and I think it's important to understand. And so the benefit, of a maintenance therapy is, the hope is, can it prevent the cancer from coming back, or can it prevent it from coming back for a prolonged period of time? There are, of course, disadvantages, and I think we heard a little bit about that from Jill. There are side effects to those maintenance therapies, so we have to balance that with the fact that if you weren't on that treatment, you would, not be on a treatment at all and likely feel better. There are unfortunately costs associated with that, missing work, driving to those doctor visits, as well as the cost of the medications. It does require you to visit us more often. And some of these are newer treatments, and we don't know kind of the long-term effects of some of these therapies. So I think when we're thinking about maintenance therapy, it's important to really discuss the pros and cons with your physician and your team, and if it makes sense for you. So some of the options include the PARP inhibitors, and so these are the 2 most common that are listed on top, and there's slightly different side effect profiles with both of them, different dosing, and so again, sometimes it's selected based on, what insurance you have or what treatment kind of side effects you had with the chemotherapy. There's no difference in terms of efficacy between them. Avastin is another maintenance drug that we can use after the chemotherapy if you had Avastin with the chemotherapy. And sometimes in certain situations, actually, you can use both of them as maintenance therapy. But also remember that observation is also a very reasonable approach, and kind of depending on your tumor genetics, in some cases we do feel that observation might be the best approach. Again, very individualized, so it's really important to understand kind of your germline genetics, or kind of what's they can see in your blood, as well as the tumor genetics, because that gives us information about how well these maintenance therapies may work. So unfortunately, ovarian cancer often comes back, and so we then have to think about how do we approach recurrent ovarian cancer. So again, I think my theme for today is this is a very individualized approach. And so there are a lot of decisions or a lot of information that we have to kind of pull in to decide what what next step, what treatment is going to be the best for you as an individual. And some of those factors that play in is how long did it take for the cancer to come back, and where did it come back? What happened during the first chemotherapy? How was it tolerated? What side effects did you have? What happened with the tumor? And what are your current symptoms? What should we really be focusing on, or what treatments should we avoid because it could worsen some of those symptoms? And then, like we clearly saw earlier today, all of you and everybody, has life events, has important family gatherings and trips that need to be considered, and it's really important that you talk to your healthcare team about upcoming events because there are a lot of treatment options with a lot of different schedules. And so we can often integrate a treatment plan based on how often, or if you have a trip coming up or a wedding coming up, those types of things really should be factored into your care. One thing I would encourage you all to ask every time you meet with someone and they say we need to, think about changing the treatment is always ask about clinical trials. That's really, I think, the key take-home point here. The only way we can improve the care of ovarian cancer is we have to keep pushing the needle forward. We have to keep trying new therapies. And the only way we can get FDA-approved therapies is we have to test them in clinical trials. And so clinical trials do allow you opportunities to try drugs that are not yet FDA approved. You're closely monitored. But I think it is really important because it gives you additional treatment options. So again, bottom line is there are a ton of different options if the cancer comes back. And it's just all of these things are factored in when we make a decision about next steps. So again, it should be really an individualized discussion with you and your physician and your team. And the person sitting next to you may have a very different approach than you based on kind of a lot of different factors. So why consider clinical trials? So this is just it's loud and I'm sorry, but what I wanted to really point out is kind of there on your right is all of the FDA approvals for ovarian cancer. So it's exciting. The needle is moving forward. We are getting new approvals. And outcomes are getting better. So that's really exciting, and that's because of clinical trials. So these are some examples of clinical trials. The orange arm is kind of where we were, the control for the clinical trial. The blue arm is how the patients on the clinical trial in the kind of experimental arm did. And you can see that this has led to significant improvement. And so again, it's really important to think about clinical trial options.
Oh, could you go back? So the orange, explain the difference, the orange.
Yeah, so the orange was the control arm. So this is an example of phase 3 clinical trials, and we'll kind of talk about the different phases of trials in a minute. But in phase 3 clinical trials, we take kind of the standard of care, or how are we treating it based on kind of current FDA approvals. And then so that's the orange arm, and then the blue arm is, the standard of care plus the experimental drug, or kind of the experimental drug alone. And it's either progression-free survival, so time it takes to come back, or overall survival. So you can see in many of these trials, obviously I chose the ones where, the outcomes are good.
Okay, so the longer it is, you've got your control. That's what standard. So that's the length of time beyond that this gives.
Yes. So the orange is kind of where the patients who have the standard, the current standard therapy, their progression-free survival. And then the blue arm is how the patients who were on the kind of the new or experimental arm did.
The trial.
Yeah.
I just want to make sure I comprehended it right.
Yeah.
Okay.
So when we think about clinical trials, they are not all the same, and it goes kind of through this pathway. So how do we get a new drug approved? First, we have to do early discovery and preclinical research, right? We have to test it out in the lab. We start in kind of cells, then we move to potentially animal models. And this is all preclinical research. A lot of MOCA's money goes into this preclinical research, and we're eternally grateful for that, because everything has to kind of start here. Once there is really promising data in the preclinical section, we move to phase 1 clinical trials. So phase 1 clinical trials are kind of the first in human, or they are trials where we maybe have seen really good outcomes in, for example, breast cancer with a drug, and now we find that, ovarian cancer, or a subset of ovarian cancer expresses that same marker, so maybe we need to try that drug in ovarian cancer. Because it's not FDA approved and not tested in ovarian cancer, it does have to start at a phase 1 clinical trial. So the phase 1 clinical trials, we're really assessing, is this safe? Are we seeing a hint of efficacy? What is the best dose? These trials often include additional blood tests to kind of monitor the blood levels, and they're smaller. So these are smaller trials, require higher monitoring, but again, all of our FDA-approved drugs have at one point started in a phase 1 clinical trial. If in a phase 1 it's deemed that drug, it seems to be safe, there's a hint of efficacy and on-target effect, we move to a phase 2 clinical trial. And phase 2 clinical trial is really where we are getting a little bit more focused in terms of what patient population do we really think this is going to work in. And so the eligibility criteria is a little bit more strict. Oftentimes phase 2 clinical trials only have one arm, meaning you're only testing the experimental therapy. It's a slightly bigger study, but this is really where you're starting to kind of look at real efficacy. And just for funding purposes and the way, as kind of funding gets a little bit tighter, oftentimes we now have combined phase 1, 2 clinical trials, or the phase 1 with kind of expansion cohorts, where the first half of the trial we're playing with the, with the dosage, and we're monitoring that. And then the second half, called the expansion half, is really a mini phase 2 clinical trial. Once that that efficacy is seen in phase 2, we move to a phase 3 clinical trial. And the phase 3 clinical trials are the ones that the company or the investigator or the institution works closely with the FDA as they design the clinical trial, because that's going to lead to potential FDA approval. So these become much more strict in terms of, for example, the eligibility criteria. For the monitoring, there's not a lot of leeway. You either fit that eligibility criteria exactly, or you cannot enroll, because again, this is monitored by the government, needs, very strict criteria for FDA approval. It's going to have 2 arms, right? Kind of like we saw in that figure. We have to be able to prove in a phase 3 clinical trial that this new therapy is at least as good or better than, what already is FDA approved. And so for a phase 3 clinical trial, you will be randomized to an arm, right? It could be the standard therapy, or it could be the standard therapy plus the experimental therapy. Whereas in a phase 1 and phase 2, you usually are not. You usually get the experimental therapy. And we can talk more about that afterwards if there are questions. So that's the phase 3. If the phase 3 is positive and it meets FDA criteria, that leads to the FDA approval. Phase 4 trials is really kind of the post-marketing, so kind of that first several years after clinical, a drug has been approved. There's continuous monitoring to look for any new signals, for any changes, and those are kind of phase 4. And those are more kind of in the background, kind of just looking at side effects and monitoring. So I think, when you're talking to your team about, clinical trials, what should I consider? I think things to consider and to ask about is, what phase is the trial? What information do you have about it? Is there more than one arm? Will I be randomized to, what are the ones that I may be randomized to? Now we often also have larger clinical trials, or maybe there are 3 or 4 arms. And so understanding kind of what each arm would mean for you and making sure that you feel comfortable being in any of those arms, because that's all done kind of through randomization and your team doesn't have control over which arm you go into either. Asking about, how many visits are required if you have big events coming up, understanding how will that fit in, because with clinical trials, unfortunately, it is a bit stricter about being able to move your appointments around because, again, it's regulated very closely. What additional tests do I need? Oftentimes in the earlier clinical trials, because we want to better understand what is it doing to the tumor. Is it, targeting the tissue we think it's targeting? They often will ask for biopsies. Sometimes these are required and sometimes they are optional, but again, these are important things to ask. And then how long can I stay on the trial? How long is this trial? Is it as long as it works? Is it for 2 treatments? And all of these can vary. And how can you tell if it's working? What kind of analysis do you have? How often do you have CT scans? How often do you have blood work? And what are my other options? If I don't do this clinical trial, what other options are available for me? So I'm going to switch completely, and now we're going to talk about targeting folate receptor alpha. So,
can I ask a question?
Yeah, absolutely.
How long do trials typically last, each phase of a trial, would you guess?
That is a great question. So, I would say the phase 1 part, kind of depending on kind of if it's a phase 1/2, would be several years. I mean, each one probably several years is a good estimation. We kind of think about, best case scenario from, identifying a target in the lab to getting it FDA approved is often 15 or so years. Sometimes we're lucky and it goes faster. We've seen some accelerated approvals based on really positive results from phase 2 clinical trials, but it's a long process. Yep, and of course it depends on accrual. I think with COVID we did see, understandably, kind of a decrease in enrollment in clinical trials and a decrease in funding, and so we've got our work cut out for us. We've got to make up some time. But when we think about clinical trials and how the treatment of ovarian cancer has moved forward, folate receptor alpha is a really interesting target. We now have an FDA approved drug, but we also have different approaches to targeting it that are not yet FDA approved. So we'll just briefly kind of talk about some of that. So folate receptor alpha is a receptor on cells that actually it's not very highly expressed on regular tissue. So in embryos it kind of is, but then once we form into full humans, that expression goes away, but it's highly expressed on cancer cells, especially ovarian cancer cells, also in mesothelioma and other types of cancer cells. But of course, our focus here today is ovarian cancer. What's nice about this is because it's not highly expressed on normal tissue, it makes it a good target because we're not going to impact normal tissue. We also have the ability to look under the microscope and assess, how much of that folate receptor is expressed on the cancer cells, how strong is that expression, and that all kind of plays into how we can target it. So, what has been really interesting about the folate receptor is that there are a lot of different approaches in ovarian cancer right now onto how to target it. So for one, if we think about even imaging or early detection, if this is highly expressed in ovarian cancer, can we just, trace it with a fluorescent dye and have it light up on imaging? And so there's a lot of research in that field. There actually, there was a clinical trial, a national clinical trial was also open at Mayo, adding radionucleotide and fluorescent imaging prior to surgery to help the surgeon see the tumor, right? Because we know that we want the surgeon to go in and take out everything they can see, and if the tumor cells now have this fluorescent dye that they can see with a special light, it helps the surgeon detect all the peritoneal nodules. And so that is still being developed and will be in, I think, a phase 3 clinical trial in the near future. So There are kind of early detection and surgical approaches for the folate receptor. There's also kind of an antibody drug conjugate on the bottom. We'll talk about that in more detail. That's what has been FDA approved and we're very excited about. But there are also different approaches, so small molecules and just targeting a drug to a folate acid derivative as well. So lots of things going on, and then we'll also talk about a folate receptor targeted vaccine clinical trial as another approach as well. So even with one target, we can approach it in many different ways. So these are the antibody drug conjugates, and so this is an exciting new approach to killing cancer. There are a lot of different antibody drug conjugates. There are a lot that are used in breast cancer already with really promising effects. We'll kind of briefly talk about another one in a little bit. But essentially what happens is because you have, the cancer cells have the folate receptor, I don't think this has the pointer, has a folate receptor on the surface. Those are those little like suction cup things around the outside of the cell. You have an antibody which will hone to that receptor. And on the antibody, those little yellow things are drug, right? So instead of infusing a high concentration of just drug through the bloodstream, they are encapsulated and added onto an antibody, so that will hone only to the cancer cells. The cancer cell will bind, because of that receptor, the antibody will bind to the receptor. It will be internalized into the cancer cell, and then because of the degradation that happens once it's in the cancer cell, it degrades and allows the drug to actually become active. And so you've got a very high concentration of drug in the cancer cell and not a very high concentration in the rest of your body. So you can give much higher doses of a drug than you can if you just give it directly into the bloodstream. So that's going to cause cell death, but we also see that a little bit leaks out. And so if you have a cancer cell next to it that maybe didn't have folate receptor on it, it likely is going to impact some of those bystander or those cancer cells that are nearby. And we also have seen that we do think it changes the tumor microenvironment, which can lead to kind of immunologic impact as well and benefit. So the FDA-approved drug that is now available to us is mirvetuximab, or it's called Elahere. And so what you can see is it's an antibody, and it's got 4 of those kind of drug, or what we call them payloads, but those 4 drugs attached. It will go into the cancer cell like we had talked about, and then it will lead to cell death. So this is now FDA approved, but the issue is with this drug, we want a high concentration of the folate receptor on the cancer cell. So what will happen is your physician will send a piece of the tissue off for testing, and it will give us the level and the intensity of the expression. And if it meets the criteria, you are eligible for this drug. What I would also say is that with this, it's important to ask your doctor kind of about that expression level. It is generally a well-tolerated drug. It does have some ocular or some kind of eye irritation, so you would be asked to do eye drops, follow up with an ophthalmologist, and so that's all discussed if this is an option for you. What is exciting though is that we are really looking at how can we continue to use this drug, and can we use it perhaps earlier. And so there are multiple clinical trials that are still using this FDA-approved drug, but in combination with other treatments. And so one is using it, for example, with the bevacizumab or Avastin. One is using it kind of in an earlier setting. One of them, we're using it kind of instead of that Taxol in the upfront setting, hoping that maybe, we can avoid using Taxol. We could reduce that peripheral neuropathy or that numbness and tingling, kind of prevent some of that hair loss. And so we're still kind of figuring out when and where to best use it. But it's definitely important to get your tumor tested for folate receptor alpha and see when it would make sense to consider this as a treatment. Yeah?
Now, you can test it from you go to the tumor itself and take that sample, or can it be tested within the bloodstream?
We have to right now test it off the tumor tissue, but what is important to remember is, if you had kind of an initial surgery, that tumor tissue is saved, and so, oftentimes, we'll just send that old tumor off. So you don't need a new biopsy.
Okay.
It can be off the old tissue.
Okay.
Yep, so a lot of it's done behind the scenes. Your team will just say, hey, we're gonna test it, we're gonna test your tumor for this, and then it just gets done, so you don't need additional interventions.
Okay, yeah, there's a reason for my questions.
Okay, and then this is all covered, so the testing is covered and shouldn't be an expense to you. So another approach, so we just talked about the folate receptor alpha, and I should say with the mirvetuximab or the Elahere, right now the cutoff is 75%. We are looking at kind of in combination therapy that level might be a little high, so likely in other scenarios we may be able to use it kind of with lower expression level, because I know that for some of you, you may have heard about this drug but then realize maybe this isn't an option because of that expression level. But do not give up hope, because we also are looking at different ways of targeting folate receptor alpha. One of them is called a CDOT. So C stands for Cornell. This was identified at Cornell University. And so this is pretty cool. So this is a very, very tiny particle. It's like a little silicone particle where it's very, very small. It's rapidly internalized into cells, but it's also rapidly eliminated from the kidneys, which is important. We need your kidneys to work well. And so what they can do is they can put a target, so folate receptor alpha on the outside, and then inside it put a high concentration of drugs, but it's very small. And so the thought is that then you do not need as much of the folate receptor alpha expression. And so we currently have a clinical trial using one of these CDOTs, but the expression level only needs to be 25%. So if you're someone who had, your folate receptor alpha testing and it was, 25% or 50%, and they said, Elahere unfortunately is not an option right now, definitely contact us. We have a clinical trial open and it goes down to 25% and higher. We also have seen, oh yeah.
What stage is that in?
That's a great question. I love it. So it was a phase 1. So we've identified the dose, and it's now in an expansion. So in essentially a mini phase 2. So we're accruing 40 women with ovarian cancer to a confined dose. So it's a phase 1 expansion.
My tumor expression was 60.
Okay. Well, we should chat.
Yeah, they did talk to me about this.
Okay.
But since my last chemo showed some shrinkage, this is delayed.
Yes. That's good too, though. Yes. So this is the ELU clinical trial that I had mentioned. And so, like I said, the recommended phase 2 dose has been identified. And like we had talked about, this is kind of a phase 1/phase 2 clinical trial. We are in the expansion cohort. So we are looking at actually endometrial cancer as well. We've got one cohort for endometrial cancer and one for ovarian cancer. Also, because we think that potentially this has deeper penetration, we are also evaluating this in women who had the Elahere but maybe had progression, and so those individuals are eligible for this study as well. There is also another approach. So this is an approach led by Dr. Block, who I know many of you know well. And so this is really looking at a vaccine approach. And so there were prior clinical trials at Mayo that looked at a vaccine against folate receptor alpha peptides, which showed some promise. But they also identified that there's kind of this immune approach to kind of eventually evade that vaccine. So what this new trial is really looking at is kind of, can we kind of make our own dendritic cells, or kind of supercharge the immune system and give the vaccine and give a different approach, a different type of immunotherapy, and really kind of, like I said, kind of supercharge the immune system 3 different ways, and approach targeting folate receptor this way. So for this clinical trial, you can have platinum sensitive or platinum resistant disease. So, you know, if your tumor progressed through the platinum, you're eligible, but also if that's still an option, you can use this if you say, I don't really want to go back to chemotherapy just yet, I want to try a completely different approach. And there's no limit on the number of prior treatments, because it is a very different approach. And it shouldn't kind of impact your white blood cell count and those types of things. So what happens is, I'm going to just do it like this because this is easier, but so what happens is, if you are interested in the clinical trial and decide to proceed, what they do is they'll do a process where it's kind of like giving your blood, but they will take out some of the white blood cells, the monocytes, but then they will put the rest of the blood back in, so that's called an apheresis. They'll take out the monocytes. In the lab, what they will do is they'll make those monocytes into these supercharged immune cells, these dendritic cells, and they'll feed them the folate receptor alpha. So these are these immune cells that, when they are infused back into the body, are going to try to find those cancer cells that express folate receptor alpha and kill it. They will confirm under the microscope and with imaging, you know, that these are truly dendritic cells, and then they go back into you. What they will then do is they will, again, they inject that dendritic cell vaccine, but you will also get once every 3-week immunotherapy. Keytruda is kind of the trade name, which you might have seen in ads, but essentially it's kind of taking the brakes off the immune system so that your own body can identify those ovarian cancer cells as foreign. And so this is a combination of that immunotherapy and the folate receptor alpha vaccine. It's kind of a complex study, but it's really exciting. And so again, if there is interest, we are actively accruing. And I just wanted to talk about a couple additional targets, and I just bring these 2 up because they are antibody drug conjugates, and that's kind of what we had focused on this morning. One is the Claudin-6 antibody drug conjugate. This is also open at the University of Minnesota, and so she's right back there. We're on teleconferences weekly, so it's good to see you in person. But this is a really exciting study that targets Claudin-6, which is also expressed on ovarian cancer and other cancers. And so we are actively accruing. This is a phase 1 clinical trial as well, but again, we are at the point where we've identified target doses and we're kind of expanding into cohorts. And so that Claudin-6 is a new target that's really exciting. HER2 is not a new target. You may have heard of that, but it's new for ovarian cancer. So this is a target that's commonly used in breast cancer. And when we kind of just use the traditional breast cancer target, we didn't see much impact, but now that we have these antibody drug conjugates, we've seen really nice responses using this in endometrial and ovarian cancer. And so we do have clinical trials looking at this as well. So in summary, I think bottom line is ovarian cancer treatment, as you are all aware, is really individualized. There's a lot of discussion, there's a lot of options. I think it's good, right? You have a lot of options, but it also is hard because you have to make decisions, and that's where it's really important to talk to your team about kind of side effects you're most worried about, schedule, all those things are really important. Always ask about clinical trials. These are opportunities for you to get treatment that are not yet FDA approved. And if it's something you don't like, you don't have to do it, but I think it's always important to ask about what those opportunities may be. And we're all very excited because there are a lot of clinical trials out there right now in ovarian cancer, which means hopefully there are going to be a lot of new FDA approvals. So I also want to, and I think you've probably seen some of these slides before, but I really want to thank you all for supporting MOCA and MOCA for supporting us. This is our team, or part of our team from Mayo at the walk. That's my son flexing his really big muscles, as you can see there, with the Mayo shirt. He loves these events. This used to be his favorite one, but then he went to the Duluth Teal event and learned about bidding. And so he did a really great job and already has in the calendar the next events. It's hard on my wallet, but it's for a good cause. So he's going to be out there outbidding you all. And then this is another picture of one of the events with our surgery team and our medical oncology team. We like to celebrate with you and all of our accomplishments. So thank you very much.